Today's topic is the role of pelvic lymphadenectomy for prostate cancer. And I'll focus on the intermediate risk patient because I think that's where most of the controversies are. But I'll touch on just general role of pelvic lymph node dissection during radical prostatectomy. But first, a little historical context. Lymph node metastases and clinically localized prostate cancer, we all probably know this, is a poor prognostic factor for biochemical recurrence and survival. And the advent of serum PSA testing has led to a stage migration where, thankfully, when we do surgery, we are less likely to come across patients with positive lymph nodes. Historically, nodal metastases were found in up to 25% of patients. As we started to operate on PSA screen patients, sort of lower risk patients, series today, depending on the series, the rate of positive nodes is maybe quite low, 0.3 to maybe 10%, depending again on the population. I think the pendulum is swinging back out now. We're operating on maybe higher risk disease. So I think these numbers will probably go up as we are understanding that there's a role for prostatectomy in more aggressive. I think in the beginning of PSA screening, we thought we can cure the lower risk patients and maybe not the higher risk patients. But I'd say the pelvic lymphadenectomy kind of as a takeaway is still, its role is controversial. The extent of pelvic lymphadenectomy is also controversial. I think there's great variability, and probably the most common lymphadenectomy template is what I would call a pelvic lymph node disruption, where the surgeon plucks out one or two little fatty things off of the general area and submits a bill to the insurance company. But there's been some literature on what is a limited dissection. Typically that's an obturator fossa dissection. What's a standard dissection? That's the iliac, external iliac, and the obturator. And then what's a extended lymphadenectomy? You'd add maybe the internal iliac area all the way up to where the ureter crosses. And then there's been sort of uber extended dissections that are discussed in the literature. But I think it's important to note that prostate cancer does not have a sentinel lymph node like area of drainage. The drainage can be quite variable, and it's not uncommon for pelvic lymph nodes to be involved outside of these very commonly described areas that we think prostate cancer likes to spread to. So it's not uncommon and to find it outside of these templates. What would be the role of lymphadenectomy if you were to say, well, on one hand, it would be for staging or diagnostic purposes. So the question would be, does it more accurately stage men with prostate cancer? And I think that the answer to that is yes. If you don't do a lymphadenectomy, you won't know someone has a positive node, and if you do it, you may pick up the positive node and classify them differently. So I think that makes sense, and the literature would bear that. Where it's a little bit more controversial is the second question of, is it therapeutic to do a pelvic lymphadenectomy? Does it improve biochemical survival? Does it improve metastasis survival? Does it delay hormonal therapy? Does it avoid hormonal therapy? I think that I would just say is controversial. I have my personal feelings on that I'll share with you. And then, we have the low risk patient, the intermediate risk patient, and the high risk patients. I think we can all agree that the low risk patient probably in some circumstances shouldn't be getting surgery, and that their chances of having positive lymph nodes is so low that probably can omit a lymphadenectomy. I think that's generally accepted. High risk patients, we know that they have a higher chance of harboring positive lymph nodes, and I think most of us would think that doing it at least for staging purposes would be a good idea. And where I think the gray area lives is in the intermediate risk patient, although we could even discuss high risk patients and whether we're changing anything by knowing about the lymph nodes being positive. So one question would be, in intermediate risk patients, would you recommend pelvic lymph node dissection with radical prostatectomy? So what is intermediate risk? There's the EAU definition, which I think is a very good definition. PSA between 10 and 20, Gleason grade, or grade group 2 and 3, so Gleason 7, or a clinical T2B. The NCCN further classifies them into favorable intermediate and unfavorable intermediate. And so just a call out to understand, how do we classify or how do we stage kind of prostate cancer in these risk categories. And the recommendations from the various societies are, somewhat variable. The NCCN would say that for favorable and unfavorable intermediate risk disease, that you would do a nomogram. In this case, the Memorial Sloan Kettering nomogram, and if the probability of harboring positive lymph nodes is greater than 2%, they would say that extended pelvic lymphadenectomy is preferred. The EAU says that extended pelvic lymphadenectomy should be performed for all patients with a nodal metastasis, a little higher bar, 5%, and they leave the nomogram up to the individual, and Briganti, Roche, Parton, MSKCC, etc. And then they further say extended pelvic lymphadenectomy for all patients following MRI-targeted biopsy using an updated nomogram. And the idea there was to put in some MRI kind of information in the decision-making process, as that became something we used often. The AUA, ASTRO, and the SUO basically are much more vague, can be considered for any localized prostate cancer, so leave it up to the person, and then recommended for those with unfavorable intermediate risk. So they're prescriptive about the risk and really don't make any comments regarding nomograms. The nomograms are actually quite good, and while we could debate the merits of one versus the other, there's, I think, enough literature on each to suggest that they perform similarly in their prediction of positive lymph nodes. Obviously, they're calibrated in different populations, so take that with a grain of salt. But the use of nomograms actually can spare a good number of patients lymphadenectomy if the goal is to find the positive lymph nodes, and seem to miss a few positive lymph nodes in the studies that have been performed. So they're good. Use of nomograms is a good thing, and I commonly will use nomograms. So in terms of therapeutic benefit, and I'm going to cherry pick the literature and cite one of our speakers, Fiona's on this first paper, and this was actually a paper that inspired a paper I wrote, which we'll cite on the next slide. And this was looking at Dr. Studer's series of radical prostatectomies and patients who've had an extended pelvic lymphadenectomy at the time of radical prostatectomy. And in this series, 25% of patients were found to have a positive lymph node, which is higher than sort of what had been published. So suggesting extended pelvic lymphadenectomy picks up prostate cancer in the lymph nodes more commonly. So, some additional information at the time. And then interestingly, with a median follow-up of 45 months, and I'd say maybe even longer today, that those that have had one positive lymph node remained free of biochemical recurrence. 40% of them remained free of biochemical recurrence without any sort of adjuvant therapies. So looking at this study, and then looking at the study from Skinner's group, written by Sia Danishmand, who's still at USC, also similarly, that patients with one or two positive lymph nodes, there was a significant clinical recurrence-free survival without any additional therapy. Both to me, as sort of a young urologist at the time, were eye-opening. And so we sought to sort of look at the same question using two surgeons at Johns Hopkins. Ballantyne Carter did a standard lymph node dissection. Dr. Walsh did an extended lymph node dissection. And so we compared extended pelvic lymphadenectomy to standard pelvic lymphadenectomy retrospectively in their respective patients. And what we found is that the extended pelvic lymphadenectomy, surprise, surprise, detects more positive lymph nodes than the standard. So better staging procedure. And then what was very interesting is that if you were to pick out create a parameter called lymph node density, which is the number of positive lymph nodes over the total number of lymph nodes you removed. So if you remove one lymph node out of 20, that would be one, divided by 20. And if you looked at patients with less than a 15% lymph node density, the 5-year PSA progression rate of an extended pelvic lymphadenectomy was 43% compared to that of 10% in the standard lymphadenectomy. So suggesting potential therapeutic benefit to lymphadenectomy, but also suggesting that an extended pelvic lymphadenectomy may be superior to a standard lymphadenectomy. We then updated, Trinity Bevilacqua updated this series and looked at actually metastasis-free survival at 10 years and cancer-specific survival. And certainly there was benefit for those who harbored small amounts of lymph node. So if you had one positive lymph node, let's say, you could do very well without any additional therapy long-term. This is a paper recently published as a randomized clinical trial comparing standard and extended lymphadenectomy from Memorial Sloan Kettering. 1,440 patients randomized to extended versus limited, and it was a negative study. Basically, they found no differences in biochemical free recurrence. The rate of complications were the same, and while randomized, the number of nodes removed for the limited was 12 lymph nodes, and the number of lymph nodes removed in the extended was 14 lymph nodes, which just seems lower than expected. So perhaps there was, and there wasn't sort of rigorous quality control in how these lymphadenectomies were performed. So maybe it was a negative trial because it was the same lymphadenectomy compared to itself, and it wasn't extended versus limited. But important information to sort of digest as we sort of conclude what our potential sort of view of this is. There's obviously stage migration bias in when you talk about therapeutic, and to say, well, this group underwent lymphadenectomy and they did better than those who did not undergo lymphadenectomy. So that could be a result of a study, and you may say, well, that means lymphadenectomy is better and the patients are benefiting. But there is a bias called the Will Rogers phenomenon. And Will Rogers said when the Okies left Oklahoma and moved to California, they raised the average intelligence level in both states. So how would this play a part in when we look at pelvic lymphadenectomy studies, is that you're taking the worst patients in one group by finding the positive nodes and taking them out of that group, and now you're putting them into the floridly positive lymphadenectomy, pelvic lymph nodes, so they would become the most favorable patients in the other group. So you take out the positive lymph nodes from one group and make the survival better, and you put these better survival smaller lymph nodes into the bigger lymph nodes, and you make the survival of that group better. And all of a sudden, just by simply reclassifying patients, you can say that your intervention was a better intervention, but it's really a bias of classification. But it remains that the data out there, that there are some patients who remain free of biochemical recurrence long-term and avoid hormone therapy or any adjuvant therapy and do very well. And I would say that had we not found those lymph nodes, maybe they do well, but I would postulate that they would have gotten some additional therapy because we left that lymph node in. And then to me, is the basis of my thoughts that there may be some therapeutic potential for a very isolated select patient. Controversial, but that is my feeling. Well, what is the risk of, all surgeries have risks, so if we're going to do a lymphadenectomy, what is the risk? What's thought to be intraoperative complications and postoperative complications are probably the two areas to look at. Intraoperative complications are low, 1.8%. Obturator nerve injury, internal and external iliac injury, and ureteral injury. So in that 1.8%, ureteral injuries are probably the most kind of discussed. Postoperative complications are going to be lymphocele, DVT, and obturator palsy, and it's not an insignificant, sort of rate of these, and it probably depends on the extent of lymphadenectomy and the technique performed. And, so there are, things that one should consider. Symptomatic lymphoceles require drainage. A lot of people probably get lymphoceles. We know that they're subclinical in most patients, and most are treated with percutaneous drainage. Very few will require additional interventions. And the Leahy Clinic folks have discussed this kind of sewing the peritoneum onto itself to keep it open so that the sort of lymph can drain into the peritoneum after a transperitoneal prostatectomy. And that technique seems to minimize lymphocyte sort of formation. DVT is another big one, and I think just kind of keep that in mind. And I think I would say that these patients can be sort of high risk for thromboembolic events and have a low threshold for non-invasive imaging postoperatively, and of course consider pharmacologic performance. I think it's worth discussing in the last 5 minutes the advent of PSMA PET in this space. So I no longer perform PL&D because my patients get a PSMA PET. Is that valid or not? Well, I think, the conclusion is, I think PSMA PET is very good. I still think that it, misses, certain patients. So we did this in the very early phases of PSMA PET scanning in this country. We did a small study of 25 patients, high-risk patients. They all had negative conventional imaging. 7 patients had positive lymph nodes on final pathology after prostatectomy. And the PSMA PET correctly identified 5 out of the 7. So it missed 2, and then it overstaged 2 patients. So there were 2 patients who were positive on the PET that were found to be negative during surgery. Important to note that the average size of a positive lymph node is small, and that could account for some of the performance characteristics. This is a picture of sort of what positive lymph nodes could look like on PSMA PET. And you could look at sort of a reasonable sensitivity, a very good specificity, and you could look at the positive predictive values and negative predictive values. Bigger studies have been performed. This is the Lighthouse trial. The senior author here was Brian Chapin at MD Anderson. We were co-authors on this. And you could look at the positive predictive values and see, that there's variability in the reader, and that the positive predictive value is close to maybe 60% kind of composite. And this is consistent with the Osprey trial, which is another big trial looking at this. And the negative predictive value is around 80%. So some things about PSMA that we should sort of know is that there is a bladder and ureteral signal that may obscure focal PSMA uptakes in lymph nodes around those areas and make it harder to discern. So that could be an area of error. False negative rates are between 10 to 20%, so you could miss some patients who have positive lymph nodes. And if a positive lymph node is seen, so if you have a positive PSMA scan, it shows an external iliac node, there's a 30% chance that another lymph node somewhere is still positive. So that is important. And I think where it's very helpful is if there is an isolated lymph node and it's outside of your template, you would maybe know about it. And if it's in a place that you can get it, potentially you can go after it. There's inter-reader variability. And then a good discussion point is when it over-detects, so like in our trial, 7 patients were found to have PSMA PET positive, but we only had 5 on pathology. Could the 2 be positive outside of the template? And in the Lighthouse trial, 50% of the over-detected PSMA PETs truly were actually positive. They just weren't in the template that the surgeon removed. So it probably does better than what the performance characteristics would tell us. So I think PSMA is a good study. I don't think I'm ready yet to abandon lymphadenectomy on a negative PSMA. And certainly, if it's positive, there's a big controversy of should we be operating on these patients, and there's been a stage migration that is, I think, a very good point for potentially our critique panel. Then lastly, I'm going to talk about just a future potentially endeavor. We're doing a trial using PSMA fluorescence intraoperatively, so injecting patients with PSMA with a fluorescent tracer. This is a patient with a left-sided Gleason 8 tumor. And we use, the Firefly technology, near infrared. There's 2 settings. This is on normal infrared, and then there's ultra-sensitive Firefly, so you'll see me switch to it at times. And while this is not a lymph node that I'm showing here, this is someone who had EPE on MRI on the left side, and at the end of this case, you can kind of see this is sensitive Firefly, and I'm looking at sort of the margin there. So I think this type of molecularly directed surgery potentially is what we have to look forward to the future. And this, kind of phase 2 trial will help inform where this will fit in our armamentarium. But very exciting technology to help us with this. So conclusions, radical prostatectomy is an oncologic operation. I think accurate disease staging guides treatment and prognosis. I think there may be a therapeutic role of PLND that's suggested, but certainly not proven. Don't forget that we upgrade and upstage patients. So there's nothing like taking a patient to surgery, finding out they're Gleason 8, and then you haven't done the lymphadenectomy, and it seems like something you would want to know what the status of their lymph nodes are. Surgical risks are real, but relatively rare, and then not all surgery is equal. There's great variability in pelvic lymphadenectomy. Thank you.